Welcome to Section 3, Part 2 in General Principles. In this part, we will be talking about histamine receptors and vasopressin receptors. So let's get started. So first, it's important to know that there are two types of histamine receptors. First, we're going to talk about H1 receptors, and then on the next slide, we'll talk about H2 receptors. Now, H1 receptors are responsible for increasing mucus production in the airways and nasal passages. So when somebody has a cold or they have an allergic reaction, these H1 receptors will be stimulated, causing rhinorrhea. And so antihistamines, or drugs that block the H1 receptor, can decrease the rhinorrhea. It's also important to recognize that H1 receptors are responsible for bronchoconstriction and vasodilation all throughout the body. So when histamine is released from mast cells during an allergic reaction, they will stimulate the H1 receptors and cause bronchoconstriction, or difficulty breathing. And also, by stimulating the H1 receptors, there will be widespread vasodilation, or edema. So when you see somebody with a type 1 hypersensitivity reaction, they have difficulty breathing and they can get edema. So now let's talk about the H2 receptors. Now these are primarily found on the stomach, and they cause increased secretion of hydrochloric acid. And of course, these come from the gastric parietal cells. And parietal cells and acid secretion is discussed more thoroughly in the gastroenterology chapter. So H2 blockers, or drugs that block the H2 receptors, can decrease acid production. So this is helpful in patients that have gastroesophageal reflux disease or acidic chyme coming up from their stomach into their esophagus. So if you can block the H2 receptors, then there will be decreased acid being produced, decreasing the symptoms. So now let's just highlight the H1 receptors in the nasal passages. We'll just write H1. And stimulation of these will lead to mucus production, and if excessive, can actually give the patient rhinorrhea, or a runny nose. So when a patient has a cold or has allergies, antihistamines can be administered to decrease the runny nose. So now I will draw in some blood vessels and draw the H1 receptors on the blood vessel, just for H1. And when stimulated, these blood vessels will dilate. And I will quickly draw in some lungs. And recall that the bronchioles will have H1 receptors, and when stimulated, they can cause bronchoconstriction. Now let's pause here for a moment and consider the bronchoconstriction and vasodilation effect of histamine. Now when a patient experiences a severe allergic reaction, the mast cells will release a lot of histamine. So we'll draw a mast cell here, and it will release histamine. We'll just draw H for short. And this histamine will act on the H1 receptors in the bronchioles and cause bronchoconstriction, or trouble breathing. And this histamine from the mast cells will also cause widespread vasodilation. And this will allow more space between the endothelial cells of the vessel, and so fluid will begin to exit the vessels and enter the interstitium, causing edema. So now I will draw in a stomach beneath the lungs. Now this is much lower than it would be anatomically, but we want to demonstrate it here. Now the parietal cells of the stomach will have H2 receptors. When stimulated, these cause increased acid production. So I will just draw increased acid here. So in patients with gastritis or acid reflux, and they have all this acid going up into the esophagus, you can administer H2 blockers, and this will diminish acid production and decrease their symptoms. So now let's do some questions to apply this. A 6-year-old boy with a severe peanut allergy is exposed to peanuts. He begins to have difficulty breathing and demonstrates widespread edema. What receptor, if stimulated, can counteract his difficulty breathing? So let's first review the receptors on bronchioles. There are beta-2 receptors, which cause bronchodilation. There are also M3 receptors, which will cause bronchoconstriction. And there are H1 receptors, which also cause bronchoconstriction. Now, because this patient has an allergic reaction leading to difficulty breathing, we suspect that mast cells have released histamine, stimulating the H1 receptors, resulting in the bronchoconstriction. The question is then, what receptor could we stimulate to counteract the bronchoconstriction? Well, if you stimulate the muscarinic receptor, that would only cause increased bronchoconstriction. So that would not be a good solution to our problem. Stimulating the beta-2 receptor would lead to bronchodilation and reversal of the symptoms. So in this scenario, what substance could be administered to stimulate beta-2? Epinephrine. Recall that epinephrine acts on alpha-1, alpha-2, beta-1, and beta-2. And recall that norepinephrine only interacts with alpha-1, alpha-2, and beta-1. So norepinephrine would not be a good substance to administer if we're trying to stimulate the beta-2 receptor. Epinephrine would be ideal. In fact, in patients experiencing a type 1 hypersensitivity reaction, epinephrine can be administered to help maintain breathing. So now let's do another question. Upon administration of epinephrine, the boy experiences a reduction in edema in addition to normalized breathing. Why is that? Now recall that H1 receptor stimulation will cause vasodilation, and this has led to the edema seen in this patient. Also recall that epinephrine, in addition to stimulating the beta-2 receptors, can also stimulate the alpha-1 receptors, which we discussed in a previous slide. And alpha-1 receptor stimulation will cause vasoconstriction. So when epinephrine is administered, it stimulated the alpha-1 receptor, leading to a reduction in edema. So now let's talk about the last receptor type, which is vasopressin. There are V1 receptors and V2 receptors. Starting with the V1 receptors, it's important to understand that these cause vasoconstriction. In fact, vasopressin can be administered to cause vasoconstriction to increase the blood pressure or to decrease variceal bleeding. Now, variceal bleeding happens when a patient with, let's say, alcoholic cirrhosis has esophageal varices, which are susceptible to bleeding, causing a lot of hematemesis and vomiting blood. In other words, vasopressin will cause vasoconstriction to decrease blood leaving these vessels. Now, V2 receptors will cause increased aquaporins in the collecting tubule, and this will cause increased water reabsorption from the kidneys. Now, ADH is discussed in great detail in the endocrinology chapter as well as the nephrology chapter. So for more information on this, please view those chapters. And ADH can act on both receptors, both V1 and V2. For example, when ADH is released in a patient, they will experience vasoconstriction to increase blood pressure, and they will also increase water reabsorption from the kidneys, also increasing blood pressure. So let's draw on some kidneys really quick here. There are V2 receptors in each kidney on the collecting tubule, and these will increase water reabsorption. And there are V1 receptors in the vasculature, and these will cause vasoconstriction. And recall that ADH, which is released from the posterior pituitary, can act on both of these receptors, increasing water reabsorption and causing vasoconstriction. As mentioned in the previous slide, ADH is discussed in nephrology and endocrinology, and you don't need to be an expert in the endocrinology and nephrology concepts right now. What you need to realize is that ADH acts on both of these receptors. Also know that ADH or vasopressin can be administered pharmacologically to increase blood pressure or increased water reabsorption. So now let's do a question to apply this. A patient is hypotensive and the physician would like to cause vasoconstriction to increase blood pressure. However, the physician would like to do this without increasing heart rate or contractility. What drug would be most appropriate out of the following if the options are epinephrine, vasopressin, or a muscarinic antagonist? Now we are attempting to cause vasoconstriction, and there are three options here. Now epinephrine will act on the alpha-1 receptor, and this is demonstrated in table 1.2. If we look at the alpha-1 receptor, when stimulated, this will cause vasoconstriction. However, recall that epinephrine will actually stimulate all four of these. And as we can see, stimulation of the beta-1 receptor will increase heart rate and contractility, which the physician does not want. So epinephrine is out. Another option we are given is vasopressin, which will act on the V1 receptor, causing vasoconstriction, and this will increase blood pressure. We're going to come back to vasopressin in a moment. The last option we are given is a muscarinic antagonist. Now this will block the effect of the parasympathetic system, which could indirectly increase sympathetic response, such as increased alpha-1 activity. In other words, a muscarinic antagonist could increase blood pressure, as we were hoping. But let's quickly review table 1.3. Recall that muscarinic type 2 receptors will actually decrease heart rate and decrease contractility. So if we block the M2 receptors, we'll actually be increasing heart rate and contractility. So of the three options given, the only real option that would cause vasoconstriction, increasing blood pressure, without increasing heart rate and contractility is vasopressin. And that concludes this section.